Total anomalous pulmonary venous return. Total anomalous pulmonary venous return is a pathologic entity in which some or all of the pulmonary venous return from the lung drain into systemic venous system and creating left to right shunt. In the total anomalous pulmonary venous return, all the venous blood from the lung enters into systemic circulation, whereas in the partial anomalous pulmonary venous return, only a portion of the pulmonary venous return goes into the systemic system. In patient with TAPVR, right to left shunt must be present, allowing the blood to return to LV and systemic cardiac output. Most commonly, this occurs at the level of the arterial septum, but may be present as a VSD or PDA. In contrast, the patients with PAPVR will have some oxygenated blood return to the left atrium and do not require left to right shunt. Embryologically, total anomalous pulmonary venous return occurs when the pulmonary venous plexus of the lung fails to fuse with the posterior outpouching of the left hilum and instead connects with the splanchnic venous plexus. It is rather rare form of congenital heart disease. PAPVR occurs when either the right or the left pulmonary veins involute, causing some of the pulmonary veins to drain into the LA. In an autopsy series, PAPVR was found in 0.7% of the population, though true prevalence is likely higher as a result of patient without symptoms. TAPVR is classified by the location of connecting the pulmonary veins into the systemic venous system, which could be supracardiac, cardiac, and infracardiac, and it could be mixed. All the patients with TAPVR exhibit a variable degree of lymphangiectasias and medial hypertrophy in both pulmonary arterial and venous circulation. In patients with complete obstruction, secondary pulmonary venous hypertension may be present. PAPVR present with some heterogeneity in terms of types and locations of anomalous connection and number of involved pulmonary veins. The majority of the patients have anomalous vein arising from the right lung, while around 10% have an anomalous vein from the lung. At least 80% of the PAPVR cases are associated with the atrial septal defect, with the sinus venosus being the most common. Unlike TAPVR, PAPVR typically does not present with obstruction. Scimitar syndrome is relevant but rare anomaly in which some or all of the pulmonary veins coalesce and descend along the right side of the heart, joining IVC near the IVC-RA junction, forming a scimitar-shaped anomalous vein. It is associated with the right lung hypoplasia, presence of aortopulmonary collaterals, and intrapulmonary malformations. This is the diagram showing the pulmonary and systemic flow. These are pulmonary veins. This is the calculation for the pulmonary vascular resistance. Pulmonary vascular resistance circulation is different from systemic circulation. They have thinner wall, less vascular smooth muscle. They are distensible and compressible. And this is the calculation for a graph showing the pulmonary vascular resistance. And these are the factors that alter the pulmonary vascular tone: vasoconstriction and vasodilation. TAPVR patient without significant obstruction present in infancy or childhood with the symptoms of the heart failure due to the large left to right shunt. These patients have dyspnea, poor feeding, poor growth. However, the complete pulmonary venous obstruction constitutes a surgical emergency. Expeditious medical measures should be taken to resuscitate the patient, including the intubation and mechanical ventilation with 100% oxygen, hyperventilation, correction of acidosis, and inotropic support. Medical measures are minimally effective and the surgical correction is required. In patients who present with the severe end organ dysfunction, some centers choose a period of ECMO support prior to operative repair. At this time, most centers choose to perform a complete repair with the use of ECMO postoperatively only if required. In the patients with PAPVR, symptoms of decreased exercise tolerance and arrhythmias arise from consequence of left to right shunting and pulmonary overcirculation, but typically manifest later in the life of adulthood. Most patients with TAPVR have varying degrees of right to left shunting to provide a limited systemic cardiac output. Above all, the clinical status of the patient is determined by the presence or absence of obstruction and anatomic configuration of TAPVR. With obstruction, regress of the blood from the lung is limited, resulting in the pulmonary venous congestion and impairment of the oxygenation, which leads to life-threatening neonatal cyanosis, and a concomitant restrictive right to left shunt with a reduced cardiac output makes such patients' state even more precarious. An important subset of the obstructed TAPVR is supracardiac patients in whom the ascending vertical vein ascends between the left PA and the left main bronchus. As the degree of the pulmonary vein obstruction worsens, the PA pressures increases, causing a further distension of the PA and the vertical vein compression. Ultimately, this leads to circulatory collapse. In PAPVR, the hemodynamic issues are caused by the left to right shunting and produce pathophysiological changes similar to ASD. Pulmonary vascular resistance is adversely affected as a consequence of the increased pulmonary blood flow. If not corrected, the lesion can cause pulmonary hypertension, right ventricular hypertrophy, and eventual RV failure. Unlike TAPVR, these changes may manifest after several decades, and thus early repair should be considered. These are the causes of left to right shunt. Pulmonary hypertension. Chest X-ray shows a varying degree of pulmonary venous congestion depending on the degree of obstruction. A prominent RA border or a PA vasculature may also be seen. Echocardiography is the study of choice for diagnosing the anomalous pulmonary venous return. The pulmonary venous confluence and pulmonary veins and connection to the systemic venous system can typically be defined. The intraoperative epicardial echocardiography is used to evaluate the anastomosis between the venous confluence and the LA. Transthoracic echocardiography is the best modality for long-term follow-up. The cardiac catheterization is infrequently used in the preoperative settings. Indications for angiography include the ambiguous anatomy that requires intervention. A classical finding at catheterization is identical of oxygen saturations in all chambers of the heart. MRI and the CT are also important diagnostic modalities, especially when anatomical clarification is needed. For a PAPVR, exercise stress testing may provide a useful adjunct to the severity of the left to right shunting. This is the flow chart for pulmonary vascular disease. Lung function abnormalities in the congenital heart disease, in obstructive, restrictive, and diffusion impairment. So the operative repair of the TAPVR is surgical, and the symptomatic patient, those with flow unobstructed, repair may be delayed several weeks or until the symptoms of dyspnea and feeding intolerance develop. For supracardiac TAPVR, the ascending aorta and SVC are retracted laterally, for the vertical vein is ligated at the level of innominate. For infracardiac, the heart is rotated superiorly and the posterior pericardium is open and the descending vertical vein is ligated. For the cardiac, the bicaval cannulation is necessary and the coronary sinus is unroofed to the LA with a patch closure of the ASD, including the coronary sinus and care is taken in suturing near the coronary sinus. The repair of the mixed TAPVR is composed of combination of above approaches. For partial anomalous pulmonary venous return, it can vary on various locations and the anomalous connection. When the PAPVR is to the right atrium or the lower aspect of SVC, a pericardial baffle can be used to patch over the anomalous connection and ASD and rerouting the pulmonary blood flow to the left atrium. If there is any concerns about SVC obstruction, a second patch can be used to enlarge the SVC. A TAPVR early mortality is highly dependent on the initial degree of obstruction and can vary anywhere from 7 to 25%. For those that survive the perioperative period, long-term results are excellent. Recurrent pulmonary venous obstruction is a problem with TAPVR and can occur at the level of the anastomosis. Use of absorbable sutures or interrupted sutures does not seem to help in this regard, and balloon angioplasty and stents have poor results. The patient who present with stenosis of individual pulmonary venous ostia with time progressively develop stenosis along with the entire length of the vein. In PAPVR, the surgical mortality is low, less than 1%, and most surgical report symptomatic relief after the surgery. Complications that can arise are SVC, pulmonary venous obstruction, or arrhythmias from the SA node injury. Thank you.